Okay, medication that will help reduce infection risk. Here's a tip you will carry with you into your NCLEX. If you are looking at a question and you go, I have no idea. First step is see if you can narrow those options down to 2. Make it a 50-50 shot. So we know that protamine is an antidote to something. What's it the antidote to? Heparin. Does heparin and its antidote have anything to do with infection?
No.
Nope, get it out of there. Now I'm down to 3 viable options. Vitamin K, which is not potassium, is an antidote to something.
Warfarin.
To warfarin. Does warfarin or its antidote have anything to do with infection?
No.
No, so I just gave you a 50-50 shot. I'm left with 2 cell-stimulating growth factors. Ecoetin alpha. That sounds a lot like the word erythropoietin, which is a native hormone that we make. What does that hormone do?
Red blood cells.
It tells the bone marrow to make more red blood cells. Do our red blood cells have anything to do with infection?
No.
Bam, that leaves me with filgrastim. What does filgrastim do? I can't hear you over the mower. Neutrophil stimulates new fills. Neutrophils. Can neutrophils have anything to do with infection? Yeah, like they maybe fight it. So if we stimulate the growth of more infection-fighting cells, could that reduce my infection risk?
Yes.
That's how we got there.
You can repeat it.
Since 2017, I'm not used to
You know,
it.
they know
And
all
what
the kids
stinks
with
is
3
they always do it during a test or a final.
Yes.
And this might be the year I snap and beat them for it.
Can I videotape?
Go, girl.
Nobody heard me say that. Plausible deniability, erase it all.
Oh, okay.
All right, true or false? There is an air bubble in the pre-filled enoxaparin syringes. Should I get rid of it before stabbing my patient?
No.
No, remember that. We normally say, oh, God, air bubbles in the syringe. It's dangerous. Get rid of it. No, not in this situation. What is the purpose of that air bubble?
Keep the medication
in place.
Exactly. That air bubble acts as a plug to keep the medication deep in the subcutaneous tissue. So you actually do inject that air bubble. Good deal for remembering that.
Why did I even say that like a question?
Should have erased it. All right, they can't hear. Make sure that you know how each drug works where it works. Okay. Alteplase removes a clot from this place. That is my one and only true clot busting medicine because it breaks up the fiber that holds the clot together. Doesn't do a squat to a platelet. Enoxaparin is just a different form of heparin. Does heparin, let me ask it this way, should heparin do anything to a platelet?
No.
No. There is an immune response that is rare that can happen with heparin that can wipe out platelets, but that's an adverse effect. I don't want it to happen. Which drug specifically goes to the platelets and tells them to stop being sticky? That is my platelet inhibitors, antiplatelets, which is clopidogrel. Okay. Closely related to him, does the same thing as aspirin. A medication that requires frequent monitoring of PT/INR. Remember, PT and INR are 2 separate labs. One of the 2 is best for this drug. Which drug do I care about those labs?
Warfarin.
That is my warfarin. Heparin, what lab do I care about?
AP.
For those 8% who chose heparin, it is up here for you to remember.
You should leave it there for tomorrow.
No, I will leave it up until everybody has left for the day. But that's why I put it up there to help you organize. Warfarin. If I say warfarin, you say
INR.
Please help me go back to that part of my life. Yes, INR.
I think we were all confused where you were going with that.
I say heparin. You say
INR.
no, you don't.
Oh, heparin.
Oh, she said
Heparin.
Oh, I thought she was repeating that.
Rerun.
My bad.
Let's try again.
Dead. I am dead.
Failure.
Defense.
Just me and Josh.
Medication for monitoring the INR and the PT is warfarin. Okay, so let's critically think this one. Post-operative DVT prophylaxis, or preventing DVTs immediately after surgery. How long does it take for warfarin to become effective? Yeah, so it can take a couple days for warfarin to even be useful at preventing clots. Well, if they came out of surgery, I want to start preventing clots right now. Right now! I don't have time for warfarin to work. So, I've got other options that will start to work immediately. What is my preferred drug, especially when we're working with bones and joint replacement?
Heparin.
Closely related to heparin.
Yeah.
Exactly, remember that one. Yes, heparin can be used for post-op DVT prevention, but we prefer to use, especially with joints, hips and knees, is enoxaparin. Joint replacement, post-op, our preferred anticoagulant to prevent DVTs is enoxaparin. Okay, cool. Let's do it one more time. I say A-I-N-R. You say?
Warfarin.
Exactly. So all you have to do is see the letters I-N-R, and your brain should have immediately clicked and go, ooh, warfarin. Okay. Subtherapeutic means I'm almost there, but I'm not there yet. I'm below the therapeutic level. If I am giving them a platelet inhibitor like clopidogrel, is INR the lab that I care about?
No.
It means nothing to me. For them, I want to watch their
Platelets.
polycyte count, their platelets. EPO-EAT and alpha. Does that have anything to do with INRs, PTTs, APTTs, PTTs? Does that have anything to do with... Should it have anything to do with clotting times?
No.
No. That sucker is going to grow me some new red blood cells. Should it increase my clotting time? Heparin. Heparin, I've got to watch a lab with it, but is it INR?
No.
No, that's my APTT. Warfarin. I want to look at their INR. What should their INR be? 2 to 3 seconds. 2 to 3 seconds. On some type of anticoagulant. I don't care what flavor anticoagulant they're on, all of them, the end result is we're going to increase bleeding time, so we need to implement bleeding precautions. So that means no blades, no sharp razors. So we'll give an electric trimmer. What other things would we want to do? Soft bristle toothbrush. What sort of things would I want to educate them to monitor for?
Bleeding gums, bruising.
Bleeding gums, easy bruising.
Change or
So I heard two. Petechiae. A-I-O-D-Q. What was the other one that I heard?
Changes to dark tar stool.
Exactly, changes in bowel habits if it becomes bright red, black tarry stool. What about urine change? Yeah, Coca-Cola.
Yeah, that one.
All the words. All the words came out at once. Coca-Cola colored urine means bleeding in the urine. Drug that will treat anemia due to kidney disease or end-stage kidney failure. So, Silverstim and Sargramostim, those guys are very closely related. What do they make? My white cells, neutrophils, and Sargramostim makes all of them. So, in case of anemia, when there is tissue hypoxia, the tissue hypoxia triggers something to happen in a certain organ. What is it? Kidneys should release erythropoietin. Well, the kidneys, they checked out. They're damaged. They're diseased. They're dead. I said, we can replace that hormone. And the drug sounds a lot like our hormone. If the hormone is erythropoietin, the drug is epoetin. So if they have kidney disease, they can't trigger to start. So we'll give them epoetin alpha. Dextra or iron in whatever form, yeah, it can treat anemia, but only one type of anemia. Iron deficient anemia. If the hormone isn't coming from the kidneys to tell the bone marrow to cook, that iron just became worthless. Okay? They still need that hormone signal messenger. So kidney anemia related to kidney disease, we're going to replace the kidney's hormone. If they're iron deficient anemic, yeah, give them iron. What if they have pernicious anemia? Is iron going to help them? No. So if we just say anemia, don't automatically think iron, because that's not going to fix any other issue except iron deficient anemia. Cool. All right, so I'm liking where my majority split here. Which lab can indicate HIT? The H stands for heparin, which is why I'm assuming 35% of you chose the APTT because you thought heparin, and let me know what lab's associated, but the other two letters matter. HIT stands for heparin-induced thrombocytopenia, meaning heparin caused the body to wipe out the platelets. So which lab, if my patient has HIT, or if I want to determine if they have HIT, what lab then would I watch?
Platelets.
The platelet count. Yeah, the CBC, which is going to include my platelet count. Do I like a platelet count of 75,000?
Absolutely not.
No. And that's going to tell me if I started my patient on heparin and their platelets were within normal limits yesterday, and I drew labs this morning and the platelets dropped to that, I'm immediately going to think what?
Put them in bubble wrap.
Well, yes, I'm putting them in bubble wrap, but what caused me to put them in bubble wrap?
The heparin.
The heparin, they have heparin-induced thrombocytopenia. Should I give them the next dose of heparin?
No.
Or what should I do?
Yeah.
They stop the heparin. We will replace it with argatroban. Aspirin. ASA, remember, is aspirin. And we can say that low-dose aspirin is a good antiplatelet inhibitor for mild reduction of risks for MI and stroke, right? Okay. We used to say baby aspirin. It is now low-dose aspirin. That is the 81 milligram dose. Okay. Low dose is 81 milligrams. So if my patient has a high risk for heart disease, high risk for stroke, and they say, you know what, I'm going to get way more benefit by taking the full 325 dose. What are you going to say to them?
No.
No, you're not going to get more benefit. What you're going to get is more risk of bleeding, more risk of tinnitus, without reducing your other risks more. So we want to keep them at that 81 milligram dose, low dose, for prevention.
They chew the 325 if they feel like they are.
Exactly. They wake up and go, oh God, Ethel, it's the big one. Oh, this is definitely a heart attack. I better just swallow that 81 milligram. Nope. Then you go for the big dose, the full 325. Chew it. Otherwise, that 325 is not going to prevent anything any more than the 81 will. Okay. So daily prevention is low dose. Epoetin alpha, it is to stimulate the growth of new red blood cells. There are complications with that. That complication comes from more red blood cells, which could make the blood thick. What happens when your blood gets thick?
Hypertension.
Blood pressure is going to go up. Absolutely. Biggest complication, one of the things we monitor closely for, one of the things we have to get under control before we start therapy is hypertension. What did I tell you about all, always, nevers? Do all anticoagulants. So, for example, my bands, apixaban, rivaroxaban. Does your patient have to come in every week, month for a specific lab to be drawn?
No.
Nah. My patient takes 81 milligrams of aspirin to prevent stroke. Do they have to come in frequently to have a specific lab drawn? Now, what's their CBC on follow-up, but they don't. My patient's on heparin. Do I have to watch a specific lab closely?
Yes.
I started my patient on warfarin. Are they going to have a specific lab drawn daily and weekly for a while?
Yes.
Do all anticoagulants require frequent monitoring?
No.
No, they do not. Know which ones do and which ones don't. What does epoetin alpha do?
Increase red blood cells.
It should increase our red blood cell count. So there's only 2 labs up here that have anything to do with red blood cells, right? That's my hematocrit and my hemoglobin. So if you can remember what the drug does, you should be able to narrow it to a 50-50. Okay? So it does nothing to do with my platelets. It does nothing to do with my white cells. So between hematocrit and hemoglobin, which one is the better measure? Which one is not impacted by fluid balance?
Hemoglobin.
Hemoglobin. Do we look at the hematocrit? Yeah, we do. We do, because we don't want it to get any higher than, I think, 50, 48. But that is not my best measure. Because let's say they are dehydrated. What would dehydration do to a hematocrit?
Increase it.
It'll increase it. Doesn't tell me if the cells really increase, just says I don't have enough broth for my soup. But hemoglobin is what hemoglobin is, and it can't be impacted by anything else. So do we watch both the hematocrit and hemoglobin? Yes. Which one is the better true measure? That is the hemoglobin. Therapies overlap. This is true because it very often does happen this way. Because remember, warfarin, it takes a long time to get therapeutic. It has a long onset. And heparin has a very short half-life. So we can keep them on heparin start them on warfarin until their INR gets therapeutic, and immediately stop the heparin. And within a few hours, it's like the heparin never happened. We're not really increasing the risk of bleeding. As soon as we get the warfarin therapeutic, the heparin goes away. And go. Effective filgrastim. So first question is, what should filgrastim do? What's its goal?
Increase white blood cells.
Exactly. We're trying to grow new neutrophils, so that will increase my white cell count. Not a side effect, that's a goal. Spleen is a lymph node, among other things. Where do white cells go to hang out? In the lymph nodes, like maybe the spleen. So if we are rapidly increasing white cell count, does it make sense that the spleen may enlarge? Yeah, absolutely true. Where in the body do we make white blood cells?
In the bone marrow.
In the bone marrow. So if we're telling the bone marrow to rapidly start increasing production, could that bone marrow get congested with cells?
Yep.
Would that maybe cause pain to the bone?
Yep.
And it will. It absolutely will. So the only thing that we should not see is a drop in blood pressure, hypotension. Okay? That is not a side effect of the medication. Everything else is. All right, alteplase or TPA. That is my one and only true clot buster. It will break a clot, nothing else will. We usually get is someone having a massive MI or is having a stroke. But time is tissue and the time matters. We are going to get the best effect if we are within 4 hours or less of onset of symptoms. Okay? So you've got a patient presents with unilateral facial droop, unilateral hemiparesis, arm droop, and their speech is garbled. What is your priority assessment question?
When did it start?
When did these symptoms start? That 4-hour clock does not start when they walk in the door. It's from onset of symptoms. Okay, cool. So clopidogrel, adverse effect. First of all, what drug class is clopidogrel in? That is my platelet inhibitor. So, would a platelet inhibitor give me URI, upper respiratory infection?
No.
No, it won't. No, it won't. Should it increase my blood pressure? No, no. All I'm doing is telling the platelets to be less sticky. That is the goal of clopidogrel and its friend aspirin, is to tell the platelets not to be quite so clumpy together. The adverse effect is sometimes when we tell platelets to do something, they say, no, I'm not doing it, go to their bedroom, slam the door, and never are seen again, and can cause thrombocytopenia. Okay? It will have absolutely nothing to do with my white cell count. That's not what the drug does. Okay? Hopefully all it does is say platelets don't be sticky, but an adverse effect is sometimes it can wipe them out altogether. Y'all are going to get this next one. You are going to get this one. I know it. ARG! They got the hit. They have heparin-induced thrombocytopenia. ARG! We give them ARG! Argatroban.